So, welcome to CardioTube. Today we're going to talk about whether radial access should be the default for PCI, and it's my pleasure to introduce my guest, Dr. Samir Pancholy from Scranton, Pennsylvania, who's one of the leaders in transradial access. So, welcome, Samir.
Thank you, Mama.
So maybe we can start off by asking you, how common is radial in the United States?
So United States was one of the late adopters of transradial access, as you know, and it has grown very nicely. I think we are up to 50% or maybe a little bit more. The industry estimates are above 50%. The registries are right around there.
Yes, and certainly in Europe, a lot of our guidelines, so the ESC guidelines, give a Class 1A indication for the transradial approach for acute coronary syndrome cases. In the US recently, Sky have released some statements about best practice. Maybe you can talk to us about those.
Sure. So the best practice document that we published in CCI late last year basically deals with the more of the procedural aspects of transradial access and what to do to maximize the better outcomes. It also touches a little bit on the subsets where radial is clearly better, but one thing we know is that transradial access should be the frontline access. As the pioneers have used the term radial first, and I think that's truly the motto that we should have.
And why do you think radial gives an advantage over femoral access?
Well, I think it has certain anatomic and physiologic benefits. It's not an end artery, so it has very low risk of causing ischemia if things don't go right, and also it's very compressible, so bleeding complications are very low, extremely low. It also has a tremendously higher comfort for the patient. I think that's the point where we frequently don't pay attention to. We want to give the patient the most comfortable procedure, and radial outrightly wins. Multiple quality of life assessments have shown that.
So I often hear people say that you can't do complex cases through the radial approach. What's your feeling about that?
So my feeling about that is, how many times do we need to go bigger than or equal to 8 French? Because anything under 8 French, majority of the radial arteries are able to accommodate. 6 French, almost 95+% of radial arteries can take a 6 French sheath and a 6 French guide. At least in my practice, I can do the large majority of my cases through a 6 French system. Occasionally, I want a 7 French system, and I use a 6-7 slender, for example, a thin wall sheath, or you can use a sheathless system if you're worried about the size of the radial artery, but the feasibility is hardly an issue anymore.
So one of the great advantages of radial is the evidence base behind it, and there have been a number of large randomized controlled trials that have shown superiority of radial over femoral. I guess the cat amongst the pigeons, however, has been the Safari trial. What's your feeling about the findings of Safari?
Safari was a very nice attempt. I think it was one more go around to test radial against femoral. Unfortunately, I think they were met with the common randomized trial Achilles heel, which is the randomization bias, where you get a lot of low risk patients, very low event rates. And appropriately so, the data monitoring board felt that it was futile to continue. So we would really never know the answer to the question they wanted to be answered by the trial. So again, nice effort, but non-diagnostic, so to say. We can't really make anything out of it.
Yes, it's interesting, isn't it? So I guess in the UK, our practice is mainly a radial first approach, so 85% of all cases are undertaken radially. Where do you think the main barriers are for its implementation in the US? Because 50% is still quite low.
True, and I think that's a great question, is that why are we not 90% in the US? Now, one thing I would say is, unlike UK and other societies, interventional cardiology in America is quite fragmented. There's hardly any centralization. We have a lot of low volume operators, and so radial being a skill-oriented technique, it does require one to do a certain volume to get skilled at it.
Yes.
And maybe that's one of the barriers. Now, technology has responded very well, and so we have much better quality introducers. The technique part has been sorted out by some pragmatic research, and so we're making some good headway to have it broadly applicable.
Yes.
Hopefully in the future we'll be like UK.
Well, thank you, Dr. Pancholy, for a very superb discussion, and thank you for lending your expertise around why radial should be the default procedure for PCI.
Thank you.
Thank you.
Thank you, Mouse. It's been a pleasure.